take the question that you did in assignment 1 and then answer it, how you would answer that question. And then the second part of it is that, suppose you sat down at Thanksgiving dinner with someone from your family and says, what's the most surprising thing you've learned? So just, in a paragraph or something, just tell me what it is.
I mean, I beat 97, so I have 3 stars.
And then there's extra
I
credit if
it
you
on
want to do
a
it.
night
It's
row.
optional, not required.
Don't have
So
that 4 star.
what I'm looking for you to do is basically go
I
and
need the
check
strategy and everything.
and see how they would answer your question. Now you may have to, I'm not sure, has anyone here been on ChatGPT? Yeah. So you have to, you may have to play
And
with
it's
it.
just annoying too.
I mean, first off, it's fairly simple, right? You have to, there's a, I think you have to register for it, but you can either pay for it or not pay for it. I would suggest at this stage not paying for it. Just go on and do that. Just go on and do the free version. And you may have to play around with the question a little bit. Because
so
your
I mean, like every
questions
single run, like kind of annoying.
awkwardly worded, and then they answer some other question. But if you want to do it, then just do a 500-word essay, just to see how it is that they answer your question. Good. Okay, now remember that's optional, so you don't have to do that. And that's doing the fifth. What I'll probably do is I'll probably extend the deadline of this until after, until the 12th, after the final. So if people look like they're getting kind of slammed, then I'll probably, if I get a request, I'll just make it do it the 12th instead. Any questions about this? So you have 2 assignments due. One's due on the 28th, and one's due right now, 5th, just to get you to get it in. So what we're going to do today is finish up talking about pharmaceuticals, and then I'll talk a little bit, I'll talk a little bit about, to give you kind of an intro to thinking about international, how to compare, or how to think about other types of healthcare systems. So last time we were kind of going through the evidence for direct-to-consumer advertising, and so the issue here is the evidence against direct-to-consumer advertising. So we went through that last night. So that was, one is that it's not informative. 2 is medicalization. So make sure you understand what medicalization means, because that's kind of a big deal when it comes to pharmaceuticals. Any questions about medicalization? What it means, or? Okay. Then we said that there's the criticism that drives up spending. The idea here is that, well, if people come in and are asking for different types of medications, is that they don't need, is that it's just going to lead to unnecessary spending. And also that it shifts it from generic drugs to high-cost drugs, because the drugs that advertise are basically brand drugs. And so people come in and ask for the brand drug, so the idea is that it raises prices. So now what we're going to do is basically go through the evidence for direct-to-consumer advertising. So this is the argument that sort of says, why is it that you should be allowed to advertise? So first is this idea that, well, anything that all these attempts to try to sort of say that you should be able to advertise for pharmaceuticals is what you might call anti-paternalist, or paternalistic. The idea being is that, well, people can make decisions about what it is that's kind of true and not true, and so they can go through and they can make decisions about. They're not naive and gullible and such. And also is that doctors are not these perfect agents of patients. So remember, the idea against that medical professions use capital against consumer advertising, because they say, oh, we're the agents. As doctors, we're the agents. And so people are going to be coming in and asking for things that they don't need, and so it's going to take them a long time, etc. So there's this basic assumption is that well, these doctors are these perfect agents of individuals, when in reality, doctors aren't perfect agents. First off, there's a lot of money that's spent on doctor advertising, it has an influence. That's a bit troubling. Also, is that there's oftentimes doctors who give advice that's not right. And the idea is that people aren't stupid. They can see what they trust and what they don't trust. So this is a survey that was done to sort of see how much do people trust what their GP said. And basically, about 58% of people trusted what their GP said, about 8% didn't trust. And then when it got down to newspaper advertisements, it was basically 1% said they trusted the newspaper advertisement, 28% said they didn't trust it. So the idea being is that just because something is in an advertisement doesn't mean
No, we can't.
the second sort of argument for it is this as well. What it does is it gets people who are poor health to talk to their doctor. So this is especially true when there's different types of advertisements. There's one where they advertise the drug, and then there's the other one where they advertise just about the condition. So they say diabetes is a serious condition. And so, the idea being, the argument for it is that, well, that's an informative type of information, because if somebody doesn't understand what they have and they sort of see the symptoms there, that then they're going to go through them, they'll be more likely to go and get healthcare for it. So there's this idea that it's not necessarily bad.
Honestly, it's really
Talking about different things and asking their doctors. Also, there's the safeguard in that these are all pharmaceutical, these are prescription drugs that are being advertised. So it's not like that they just go through and buy them on their own. All that these advertisements are doing is basically just telling people that they have to, that they should go and ask their doctor if this drug is right for them. The third thing is that, well, it sort of says that the only reason that so not only are doctors not your perfect agents, but direct-to-consumer advertisement works because there's problems in the doctor-patient relationship. So that, that if they, when they go through, they look at different types of studies to sort of see, well, how much are doctors misdiagnosing and things like that, is that the numbers are pretty high. And so this is the view of drug companies. So drug companies will basically say that, that it's not, that what they're trying to do is that they're trying to help patients by making them understand that, what their conditions are. And it's because the healthcare system is not necessarily seeing everyone as often as they should, and that people aren't getting regular checkups and things like that. So therefore, this is a necessary thing. Number 4 is that provides information. And so, they point out that actually to all groups. And so the point here being is that one of the criticisms of banning it is that you think, well, who's going to get information about different types of drugs and conditions? Well, it's going to be people who go to the doctor and people who are basically have other types of means of getting information, such as the internet and things like that. So the point being is that, well, if you ban direct-to-consumer advertising on televisions, or that you're not necessarily going through and mean that people can't get information on the drugs. It just means that not everyone can get information on the drugs. And then the 5th thing is that, well, there's nothing really wrong with medicalization. So there's been studies that have gone through and looked at kind of the different types of effects of pharmaceuticals. And they find that, when they look across countries, I know they're small, you can look at them yourself. When they look across countries, what they see is that there's actually, people who are on medications have better health outcomes than people who aren't on medications. So, there's not really much, you would expect that if medicalization was truly just making up different types of conditions that they're going to be worthless drugs to, is that you wouldn't see any benefit in terms of life expectancy or health or anything else. But because there is benefit, it suggests that, well, it's not, they are treating real health conditions. Okay, so, that's the arguments for and against consumer advertisement. There is this, I think that the conclusion being is that around the world is most places don't allow consumer advertisement. In the US, it's kind of been something like that. It's now there's not that much debate about it at this point. I don't think that, if you look at what the FDA does, that they require all the different types of information about all the horrible side effects that and that kind of, I think, cools people's enthusiasm for drugs. At the same time, I think the critics are sort of assuaged because it's sort of, well, these people are getting all the information. But this came up just more recently when it was when the FDA tried to allow warning labels on cigarettes. So if you look at a cigarette pack, right, it says things like cigarettes can cause cancer and things like this. Well, in other countries, they do things like this. They have on their cigarette packages, they have very graphic type of displays.
I can't lie. That's kind of cool.
So this is what the FDA tried to do, is that they tried to sort of allow public health to kind of come through and put this type and require this put this type of graphic displays on. And so the cigarette companies, they went to court and they said, no, you can't force us to do this. And the FDA said, well, we can enforce packaging. So we can go through that, we can kind of say there has to be warning labels. And the cigarette company said, well, this is not providing information. So therefore, you can't, it's violating their free speech because you're making them do something. So what do you think? Should cigarette companies be made to put on these type of graphic warning on their cigarette boxes? As a, because the rationale is that, well, this is the consequences of smoking, so it's providing information about the consequences of smoking. So give it show of thumbs, how many say yes? The cigarette company should be required to put this type of information on there versus no, cigarette companies should not. So I see all. How about McDonald's? Should McDonald's, if the FDA came through and said McDonald's, well, your hamburgers are causing obesity, and which causes diabetes. So therefore, we want to go through and show, we're going to require that on all of the Big Macs, you have a picture of a diabetic foot that's going on. Agree? How many would say yes, that's fine, versus no, that's not fine? Okay, yeah. Yeah. So you think that they should be allowed?
I guess.
Okay. So let's say, so is eating McDonald's healthy? No. So therefore, should they be forced to put on things like this? Yes or no? Yes or no? You can't go halfway. You have to say yes, they should be, or no, they shouldn't be. No, why not?
Okay, I thought he was gonna shoot that. Guard him.
Okay. So you're saying is that, well, people are adults, and so that they know that. On the other, should cigarette companies be required to put the little thing on there that says that cigarette smoking can cause cancer? I would say yes or no. Say yes, they should be forced to put on the label that says it causes cancer, versus no, they shouldn't. Okay. So you say yes to that. Does that violate their free speech? I mean, is that because that's the argument, right? That this the government doesn't do this with other things. They don't come through Toyota and say, Toyota, on your advertisements you have to show pictures of car crashes, bloody bodies. They don't do this with other things. So what's the rationale for why you would do it? When would you do it versus when would you
There we go. Finally.
Well, it seems to be it's information. So the question is, does this provide, I mean, so the label
There we go,
here
finally.
is that the label provides information. So therefore, it's kind of okay to go through and to require that they do that because it's information. Same thing for alcohol. Alcohol, package says that pregnant women should not at risk of fetal alcohol syndrome if they drink alcohol and things like that. So those are all seen as information. So the question is, well, does this provide information, or does it just sort of, is it just aversive? So if you think about imagine that the FDA came through and said, every time that someone touches a cigarette package, they should get an electric shock. That would be aversive, wouldn't be information. And so this is aversive, and the question is this information? Well, the FDA said no, and it's kind of stuck in that. Going through the current situation is that the FDA has kind of backed off from doing this because even though there's been studies that are coming out and sort of said, well, actually, these things do provide information, and that people's knowledge increases. If you make more salient, then people's knowledge increases. It hasn't led to that.
We didn't need to let him shot this long shot.
Oh, I couldn't shoot it.
Okay.
Yeah, I took too long. Hey, okay.
Last thing about that. So, as I mentioned in the Inflation Reduction Act of 2022, one thing that it did, it allowed Medicare, to negotiate drug prices. So this was for the first time Medicare had been banned from doing that, or since Medicare came into existence, and especially they were banned from doing it from 2006 when Medicare Part D was enacted. So, but now they can. So the question is, well, so what's going to happen? Right? What's going to happen when they can negotiate drugs? So the legislation basically said these things, right? Negotiate pharmaceuticals that meet the criteria. Small molecule drugs for 7 more years. Biologic approval 11 more years ago. Why is that significant? Why is the 7 or more years or 11 more years significant?
Bro, they know.
Yeah. It's like what's the period of time that drug companies really care about? And that's what the patent is. Right? What's the patent? How many years is the patent? 20. So basically what this is saying is that Medicare can't come through and a new drug that comes in the market, like take the COVID vaccine. It's like they're not able to go through to negotiate the COVID vaccine because the COVID vaccine came in less than 7 years ago. So it sort of says that, well, you can only do things that are 7 or more years. So basically they've given them a run of being able to get their profits back on the development costs, right? By being able to just sort of charge higher prices. So it said that, so Medicare had said that they're going to do 10 drugs in the first year and then increase it to 20 drugs after that. And the first 10 drugs are going to be listed in September 2023, and they were. With the prices going into effect in 2026. So it's not happening immediately, but it is kind of occurring. And then drugs under Part B will be negotiated in 2026 and go into effect in 2028. So this led to some speculation about, well, what would Medicare do, right? So these were the 10 drugs that kind of initially thought were going to be the ones that they might target. So the reason is because, here's in this column, this third column, it says Medicare Part D spending. So this is how much they were spending on each of these different types of drugs. And then over here is the number of beneficiaries, it's 2.6 million people. And then on this last column is the year that it was approved. So all these things are more than 7 years old, just like they have to be, or 11 years old, the drug. And then they have a certain type of generic name, which means that that's essentially the formula. And so the thought was that they were going to go for these types of anticoagulants, like warfarin and things like that, diabetes treatments, oral cancer drugs, inhalers for asthma, and then anti-inflammatory
Too much
drugs.
space on this place.
So, what does this mean? Why are they picking these ones? Well, what they were doing is that the legislation said that Health and Human Services was supposed to look at the comparative effectiveness of treatments. So I think I mentioned this briefly, but back in when the Affordable Care Act was coming through, is that one thing that the Obama administration did was they started PCORI. PCORI is the Patient Outcome something research center. It's like a quasi body within the government that looks at different patient-centered outcomes. And that what that means is that they fund studies that compare how effective things are in actuality. So what they're basically trying to do then is they're trying to target drugs for which there are other types of conditions, other types of treatments that might give the same or not that different outcomes. So what they're not trying to target then drugs for which it's going to be the hepatitis C drug, for which there's no real alternative to the drug treatment. Those aren't the ones they're going to do. They're going to target things for which there are other types of either drugs on the market that are similar, or that there's generic drugs on the market that are something similar, or that there's other types of treatments. So like when you think about that, you look at this thing, anticoagulants, right? Lots of different anticoagulants in the market. Diabetes treatments. Well, they have diabetes treatments here, but there are also different types of ways they can treat diabetes. So what they've done is that it's basically saying to them, go look around and see what and make sure that when you go doing something, you're looking at the relative effectiveness of drugs. The other thing is that they focus on these sort of the short and extended and long monopoly drugs. So that short monopoly are drugs that are 11 years or fewer. Extended monopoly are drugs that are 12 to 15 years past approval, and then long monopoly drugs are drugs that are almost off label, so almost the patent's almost off. All right, so these were the actual ones that were chosen by Medicare. This was just announced. These 10 drugs. I have no idea what these drugs do. I started reading about it. You can kind of get a sense about what they were trying to do with this, but other than that, we'll have to wait and see. All right, so what type of impact is this going to have? Well, just remember that the issue is that today, that Medicare is pretty much just whatever the drug companies kind of charge. In essence, they were paying the average cost rather than the marginal cost, the production cost. So in theory, this is going to allow Medicare to basically damp down on the price by going through and getting closer to marginal costs. Will it actually do this? Well, there's a reason to be skeptical. One is that the drug companies pay a lot of money to politicians, and so it's part of the reason why this has been slow to be enacted in all these different years is because drug companies would go through and say, well, look, if you do this too aggressively, then we'll just pull all of our research development out of the U.S. and go to Europe or go someplace else. But then more generally is that, well, there are ways that you can go through that you can negotiate. So for example, the way that other countries do it is that they go through that they use the market power to essentially as the way to negotiate prices. So I'll give you an example. There are various drug companies and drug agencies around that do this for government. So Pharmac is the one in New Zealand, but there's the Pharmaceutical Benefits Review in Australia, and there's NICE in the UK, and there's QUIDI in Germany. And so most countries have this type of agency that does this type of negotiation. And so in a country like New Zealand, what they do is that they basically have, for medications, they'll have 3 different types of categories of medication. They have those that are on schedule, there are those that are off schedule, and those that are not allowed. So what that means is that On schedule means that when you go into a pharmacy, all you pay is $15 per year. Regardless, it doesn't matter how much the drug costs, is that you pay $15 and then the government pays the rest. So that's an on schedule. An off schedule means that you can go in the pharmacy, if you want a prescription of some drug that the government's not going to subsidize, is that you can do it, but you pay the full amount. So rather than paying $15, you might pay $100 or $200. And then finally, they just, for some, some drugs, what they do is they just say, well, we're not going to allow this drug company to sell this drug in here. We're only going to allow this drug, Gilead, to sell the drug, and not Merck can sell their anticoagulant. And so it means that some drug companies can't go in and actually just sell the drugs on this. So what they do then is that they use the fact that they can control the number of people who are going to buy that drug, who are going to use that drug to negotiate prices. So suppose you had two drugs, right? You had this anticoagulant and the hepatitis C drug. And that the anticoagulants are ones where they sell a whole bunch of them. And the hepatitis C drug is one that is very expensive, but also very rare. So suppose, I just made these numbers up, suppose that it was $50 per treatment for the anticoagulant, and there was 5 million treatments per year. And so the total revenue was about $250 million. And for the hepatitis C drug, assume it sells for $1,000 and 10,000 treatments per year. So it'd be basically $100 million. So if you look at these two drugs, you would say, well, the total amount that's going to be spent on them is $350 million. And suppose that there are just, there's only two companies, and those two companies split the market. So that they each sell, so that company A sells $50, and they sell 250,000 treatments, and so basically they're making $125 million on this, same with company B, and they both make $50 million. They split the market on hepatitis C, so they make the same amount there, and so their total revenue is basically they're just splitting the revenue. Okay. So just imagine you have two companies. Well, what they can do, what governments do, is that they go to one company and they say, okay, company A, we're willing to let you be the only company that can sell anticoagulants in the country. But you have to give us a better price on your anticoagulants. So if they did that, they would say, okay, company A says, all right, fine, we'll reduce our price of anticoagulants from $50 down to $40, and we'll reduce our hepatitis C drug from $1,000 to $750.
I saw you.
Company B says, well, we're going to keep our anticoagulant price the same, but we'll reduce heavily our
I didn't have health
hepatitis C drug.
insurance. Not because I
And
didn't
so then
want
what the government does is it looks and says, all right, so under which of these different things are we going to spend more and which are we going to spend less?
I am not.
So in this case, if they did that, if they got all the rights, they would end up spending about $275 million a year. And if B got all the rights, they would still spend $300 million a year. So they would say to A, okay, A, you get, company A, you get the entire market. So what they're doing is that they've gotten a lower price by excluding company, making so company B can't sell the drug in the country.
8:40 departure time.
Now, as you can imagine, so let's take Medicare. What this means for Medicare is that if there's two companies, Merck and Gilead, and they both sell some type of common drug, anticoagulant, is that what they would say to the two companies is, okay, give us your best price. And then the company with the best price, what we're going to do is we're going to only allow only subsidize our patients, our Medicare patients on your drug, and we're not going to subsidize on the other drug. So that means that people could still buy the other drug, but they would just have to pay full price. Drug companies like this.
I don't know. Honestly, when I did that last
Drug companies hate this. Drug companies in countries around the world, what they do is that they basically always threaten that they're going to pull out and not sell more drugs in the market if the country gets too aggressive in terms of their
I want to make
for
sure that some
negotiations.
really heavy sets
You know, they're willing to do it,
probably
and they've been willing to do it in small countries like New Zealand,
inclined barbell bench.
Germany, and things like this, where they're big markets, but not
Pump
huge
as possible
markets.
with
But the U.S. is a
outside
gigantic
flies
market.
or cable
So
sets.
are they going to go through and allow basically?
I'd love incline,
How will they push back in the U.S.?
but they got rid of the.
So the question
They
is,
had
you
to
know, how
have
big of an
incline.
impact it's going to have in the U.S. is how
So I
aggressive
guess I do
Medicare
don't
wants
mind.
to
They
be.
replaced them with.
You know, if Medicare just
Once Smith
negotiates
Machine got
small
replaced
price differences,
with,
then the drug
Squat
and
Rack,
allows, you know, drug companies to get different shares of the market, then they'll probably say fine.
I would have preferred
But then you're not really
the
going
other
to,
Smith machine.
it's
got
not really
replaced
going to
with-
save much money. On the other hand, if
Yes, the other
Medicare
Smith
comes
machine got
through
replaced
and
with
gets really aggressive
another pair of
with the
leg
pricing,
extension and
and what you'll
hamstring
see is you'll
coach.
see politicians start to
Yes,
scream.
those were good
Because what they'll
moves.
say is they'll say,
But
our
they should've
people, our
left it
patients are, you know, my
the other way
constituents are
around.
coming to me,
You know,
and they're
Smith
telling me
machine,
is that, you know, that
I don't
the
think
merit
nobody
drug
really
is
hates it
actually
now.
best
It's
for
kind of
them,
like a
and yet, you
2000
know, their Medicare is
sort of
not
joke.
allowing them
But I love
to
the
have it.
Smith
Instead,
machine squats
they're
are pretty
being
cool.
forced to use this other
Smith machine
Gilead
bench.
drug that's not as good.
It's
So
one of
that's
the
what's,
staple
so if Medicare
principles
becomes
for chest.
too aggressive, then that's what's gonna come down
I
the road.
used to do
You'll start to hear
machine and a shoulder press too.
the cries come out that, you know, essentially is that they're restricting choice.
But yeah, I think
All
incline
right.
barbell is going to be the start.
So that's why jury's out in terms of whether
Whatever
this,
comes to mind.
you know,
Cable press,
whether
cable
Medicare is
flies,
gonna,
machine
is gonna be able
press,
to
kind of
actually
whatever.
bring down prices a lot.
See how it
Um,
feels. But
And I
even though
think
am
it's
changing up the
important
volume
because
the
if you
basic
look at
style
like
of my
when they're
chest
starting to
press
look at
is
ways
still
to
the same.
reduce the budget or
I'm still going
balance
to
the
start off
budget.
the first portion
Like, for example,
pressing,
Biden, a couple months ago,
machine,
when the
dumbbell,
budget
barbells,
negotiations were first
whatever.
starting, he came out with a
And
plan,
then with
and that in this
lighter
plan,
squeezing
he had
sets,
tremendous
with flies
savings that were gonna come from
for
healthcare.
stretch.
And most of it came from
Some
negotiating
loose
Medicare
stretch
prices.
position, of course.
And so,
And
if
then
that's
with the
true,
pull-ups,
then that means that we're gonna get
bilaterals
really aggressive
on,
about it, in which case then
You know, I
drug
can do some
companies aren't
dumbbell, I
very
can do some
happy.
machine.
And you can expect
I
that
love
to
doing
start to
cable
hear
lateral raises,
people
do one at a
complain about
time.
it. On the other hand, if they're not very aggressive about it,
Your side
then they're
delts,
not
I
gonna save
feel
much money. So
there's not a lot going on.
it's a bind.
So don't be dissuaded from, you know, doing 6 or 7 sets of
All
side
right.
lateral raises in
So
a row.
that is,
Just because there's only one movement which is going to hit your side delts, doesn't mean that your side delts
drugs. Any
require that
questions
much
about
volume.
drugs and pharmaceuticals?
I think it's kind of foolish to hit quads with more volume than hamstrings arbitrarily. Or to sort of think, okay, well, you know, my shoulders are kind of a small muscle. They don't need so much volume as my chest or my legs. Like that kind of just, I don't want to say senseless, but that's sort of just kind of arbitrary choice of sets for any given muscle for whatever given characteristic of the muscle that people say. You know, I'm pretty much just kind of hating on road science, but you know, I think each muscle needs to be stimulated in a proper way, and for you specifically, you got to figure out how the fuck to do that. But I think enough of this little ramble. Let's just get in there, get started.
Okay,
I can
last
probably foresee that in
we're
about
gonna cover in class
a little longer than
is international.
1 hour,
is health in other
check at
countries.
the chest pump.
So the reason why I focus on healthcare in other
What's the word
countries
I'm about to
is
say?
because, you know, every
Two
country
syllables.
is kind of set up their healthcare
So
system a
after
little bit
the
different.
proper cable
And yet
warm-up,
they all kind of
triceps,
face,
rear delts,
and
lats,
so they all
my
face
chest.
problems. So
And
there's
then a
no
couple
perfect
reps
kind of
with
healthcare
plates,
system.
2 plates,
in the
3
world.
plates,
Um,
and now 3
but
plates and a
what,
quarter.
you know, but the type of system you have kind of determines what kind of problem you're
Now all
going
that's
to
left
have.
to do is
So like in our system
hyped up
here,
for it.
we have problems with poor access and we have problems with high cost. You know, some problems with quality of care too, but not so many. You know, compared to other countries, it's not that big. But it's really high cost and poor access, meaning that, you know, there are a lot of people who don't get health care and that, or only get the very basic things, and that it's really, really expensive. In other countries, like if you go to the UK, you know, they'll talk about the politicians talk about the cost of the healthcare system, but people don't usually talk about it that much, as the population doesn't see it because healthcare is pretty much free. So in the UK, the thing that they have is that they have questions about quality of care, and especially about waiting
starter.
times, like how
Honestly,
long
I thought
it
that
is-
last one-
it takes to get care.
I
Same
was
thing in
hoping I could
Canada.
muscle through that
Canada,
last
if
one.
you
But
listen to some of the
That's
things on the
failure.
Canadian system, that what they'll say is
Let's
that
drop 3 plates and
Canada
then
has
just
such long wait times.
So
And so that's typically what you see. You see
I wouldn't say I'm
countries
at a
that have
crossroads,
universal type
but I have
healthcare
two
systems.
conflicting beliefs in my
Their
mind.
problems are wait times.
Right.
And
I
the
want to
U.S.,
do
which is about
really heavy,
every
crazy
country that
sets.
has
I think that's going to
modern type
stimulate some
system,
muscle growth.
is that the problem
But then
here
I
is
also
not wait
like
times.
lighter
The
squeezing
problem is
sets
just
too.
access and cost.
So should I start with
So what I want to do is
squeezing
give you a
sets?
framework for kind of
I usually
to
start with
think
the heavier
about
sets
how
because I
you
feel like
can
I'm
think
fresher and I
about
can move more
healthcare
weight.
in different types of countries.
Whatever. As long
Right,
as
so
the
if
sets
you
are hard,
remember way
I
back
don't think you
when
need
the
to
course
get
started,
too
we talked
nitpicky
about
with
the
it.
four
Every time I
types
talk
of
about like,
healthcare
oh,
systems.
maybe I should do this kind of set
I'm
or this
going to
kind of set.
expand it a little bit.
Let's
Because
say
now
that
we want to talk about
I do a workout of 5
about
hard-ass working
about sort of the
sets.
structure in terms of who
I
pays
think
for
no
it.
matter what
But also
orientation,
what the
rep scheme, I think
what
the
the,
results
whether
are going to
the
be very
providers
comparable.
are
Like I'm just
private
nitpicking like the
providers
5%
or
or whatever.
providers
If you go to the
paid
gym,
for
even
by
without a
the
legit
government.
plan, and you
So
just destroy your
we
chest
talk
one
about
day,
an out-of-pocket
you destroy
system
your back
in
the
India.
next day, you totally kill your
So
legs
in
when you
India,
touch that.
healthcare
Maybe you
providers
take a
and
rest day if you're
hospitals
into that.
and doctors
And you
are
eat your protein,
private.
I think you're
They're
going to have
not
some
paid for
solid
by the government.
results.
In the U.S.,
I think
for the most part,
probably
if you have
80% of all the
employer-based
results you can get are
insurance,
just
and then you go
effort-based.
through your use
And then the
Mercy,
rest is going to
that's
be
a private
maybe
provider.
dictated by your
Golden Valley is a
nitpicky
private provider. All
optimality or
the
whatever.
different type
But
of healthcare that
let's
you
not
use
think
are
about
all
any of that
private
and
providers unless you're
find a song to throw
in
3
healthcare
plates around.
service or if you're in the veterans healthcare. For Canada they all have private providers, meaning is that if you go to Canada, the doctors and the hospitals are all private. They're usually non-profit, but still they're private providers. And then the last one is the UK, and the UK is primarily a government-run type of healthcare system, meaning that hospitals are the major hospitals are run by the government. Primary care tends to be private, in the sense that doctors they're not on salary from the government, but they're reimbursed from the government, and so they're pretty close to
I
the
wanted to get a little partial out at the end.
government employees.
Okay. 2 good sets of incline bench.
So the general
Let's call it
framework
there.
I want you to kind
I'll
of
find
think
something
about
else.
is this thing where you
Thursday
separate
night
out
football on
the
Prime.
people,
It's on.
that's us, from the one who funds healthcare, from the one who purchases healthcare, from the providers. And so the basic type of framework is that the population, they get healthcare either by just having paying user charges to provide it, or they pay it by some type
given
of
me
taxes
blessing.
or contributions or
Typically, these
something
cables
to
are
a
a hot
funder,
commodity.
and
and I
that
can never
then
get
there's
a hold of
someone who
two at
actually
once.
purchases the healthcare,
So
and
maybe
that
I should come
purchase
in
and
later,
then they
more
purchase
often,
it
make
from
use of the
providers, and then the providers
lower
they
fucking
provide
population
healthcare to people.
but moderate weight. I like
So
to
the
go a little bit
simplest
heavier.
way to think
But
about this is the
with the
private
cable presses,
is an out-of-pocket.
I'm really focusing on trying to like
So
squeeze
this is
through
the model
Like, I
that
almost-
exists for
in my mind, my mental
buying
key
hamburgers.
is I'm like trying to pull
Buying
the
hamburgers,
inside of my
you
elbows
have McDonald's
together.
as the provider.
I'm not thinking about
You're
pushing through
us,
my hands. I'm trying to like
as the people who buy hamburgers.
my elbows
And what
together.
happens is that we go to
If that's,
McDonald's and we look
if
at
that
it and
helps
we
you
say,
at all.
okay, I want
But
these
whatever you can
hamburgers
imagine
or this,
to get
and they say,
as crazy
okay,
to squeeze as you
buy us
can,
for those hamburgers.
that's what you should be doing.
So there's no
So
government
let's throw one
agency
around and see how it
comes in
feels.
and says, oh, well, we're going to fund your hamburger purchasing from McDonald's for you. It's not like you can just walk into McDonald's and get all the hamburgers you want and the government will pay for it. It's just it's a regular private, it's a regular type of marketing interaction. Well, the key features about this is that, well, there's no role for government at this point to come in. The providers are all independent and people are funding it independent of it. But there's also, in this type of system, there's no equity, right? Essentially, if you've got money, then you get healthcare. And if you don't get money, then you don't get healthcare. So the problem with this type of system tends to be that you don't have problems that exist.
Let's do one more, a little
The
bit
government
longer.
have to try to regulate it. But what you do have is you have the problem or that people without healthcare, without money, don't get healthcare. The second type is the private insurance type model, right? Which is kind of what we have in the US. There's a couple different types of this. So one is what most people have is that we buy insurance. In fact, you could actually, for a lot of people, what they do is that we work for a company and it's actually the company
Let's do
that
some cable
pays
flies,
for
but
part of our
we're
insurance.
approaching the end for
So
sure.
we pay part of it, the company pays
Dude,
part
this
of it,
burn.
but somehow the insurance company gets the money. Then the
I
insurance
definitely want to
company,
finish with these cable flies. I
you
don't know
know,
how many
they
sets I'll do though.
either have some
I
type
think I'll just go
of
by feel. So
association with
set one.
providers, or they don't.
No drop sets, no
You can have an
nothing.
insurance like health
Burn out
insurance
like crazy.
policy where you know, you can choose your provider.
Actually, this is
You
worth
can just
mentioning.
go through,
You know,
and then you can
it's-
put in the provider you want.
It's gonna do you
and the
good to
insurance
like
company
think
will
about
just
your
pay for it.
cues. And like,
That's
okay, I
usually
gotta
a
keep my
really
shoulder blades
expensive
retracted. Oh, I gotta flex my, you know, I gotta keep my front delts out of the
You
equation.
know,
Like,
I-
that's all good.
You see
think
the
about
offer
it
that,
set.
but it used to
But
be
don't
fairly
neglect.
common, that you could
Just
pay a
fucking
lot of money, and that
have
you would
that-
have a plan whereby
Like,
you
you should feel like you're
you
in
could
a
just pay
fucking anime
whatever hospital you
hyping
want,
yourself up when you do your
whatever
set.
doctor you want,
In
the
all
insurance
honesty.
company would pay for it.
So let's throw this shit around.
Travel insurance, so in that case, then this doesn't exist, right? There's no relationship here. You then go to the provider provides you services, you send a bill to the insurance company, and the insurance company then pays the provider. Travel insurance kind of works this way. Like if you ever get travel insurance when you go overseas, the way travel insurance works is that you know, if you have to go to the hospital,
One more.
is
I
you
think
go to
one
the
more and
hospital,
chest is
you
done.
pay for it, and then when you get, then you submit a bill to your travel insurance company, and they reimburse you. So in that case, they don't actually even pay the providers, you pay the providers. So you can see is that that's kind of a risky type of thing to do that, because if you go through and pay, and then the insurance company says, no, we're not going to pay that. Like a friend of mine, she went to Guam, and then she was walking on the sidewalk, tripped and fell. She lives in New Zealand. Tripped and fell, banged up her knee. Got taken to the American hospital there in Guam. In the emergency room, they treated her. And then as she's leaving, she's from New Zealand, so she wasn't quite used to having to pay for health care. As she's leaving, they said, "Oh, you owe us $9,000."
I love those bent over flies as a finisher.
So-
Just stretch.
She basically had to whip out the Visa card,
Go find
pay
someone to close down
$9,000.
for side delts.
And then what she did is that she put in a reimbursement for the insurance company. Now the insurance company, they may have said, "That's crazy. We're not going to pay $9,000 for this."
Get Google
And
Pixel
in
8
that
Pro
case, then
free
they
with
may-
eligible
they may
trade-in
have
at
said, "We're
AT&T.
going to pay $3,000." And so then they just reimburse her $3,000.
So in no way is this
And so
list
then what
over.
does she do? She could try and go back to the hospital and say,
You know,
"Hey,
I'm not so.
how about if I pay you $3,000 instead of $9,000?"
I'm not so
The hospital has their money.
I'm not so
So they're not
enthused that
gonna
I
do
can't.
So that's why this is a very
Ego
risky
with a
type
pump
of thing.
check.
If you're on a type
I
of
gotta
insurance
see
plan
what
where
fucking pecs
where
are.
you have to pay and then you get reimbursed,
They
is
feel
that
pretty
it puts you in.
inflated. It's like I got a boob job from.
Now,
Houston.
if they, the more common thing in the US then is that there's a relationship where the insurance company has a relationship with the providers. And so this is kind of where managed care plans come in, or any type of insurance. So, if you think of Anthem Blue Cross, what Anthem Blue Cross has done is that they have
What do you think?
they have a formal relationship with providers, whereby the providers agree that these are the prices that we'll charge our Anthem Blue Cross patients. And so as a result, Anthem says to the patients, if you want, as an Anthem, you can only see our providers. So that's a common type of relationship. It can also be more direct than that. It can be like a Kaiser, where Kaiser makes, basically puts the
I feel like I
doctors
can't
on
even
salary.
Reach
And
my arms up to do a
and
good
so you can have a managed care
double
plan that
buy
works
shot
this
to my
way.
pecs are
So
like
it
my
depends
fucking,
on how firm this line is
upper
here
arms.
in terms of the current
It's like I
plan.
got bad posture, kind of walking around all hunched. No, but
Okay.
fucking-
The next type is what's called social insurance. So a social insurance plan, that's where, people pay sometimes contributions, but they also pay taxes, and the government pays into these sickness funds.
Holy shit.
So this is kind of what Germany is. So I've talked about, I think I mentioned Germany as being a private, privately insured type of country like the US, and it's not quite true.
That's for a better chest.
It's a little bit more
But then again, I
complicated,
guess I probably.
because what they do is that they
So,
basically, they have a sickness fund for this, and so people pay in money to this,
Heavy
it's like that,
good
how we
stretch
said
of
there's
flies.
a social security
Super good
trust
burn
fund
with those
that sort of
cable
keeps
presses.
money that's
Like,
separate from
with bench, I get a
what the
decent amount of
normal
fatigue,
government can spend.
but I'm not seriously
It's the
burning
same type of stuff.
as much as I am
So
when I do
it
those
sort of
cable
keep
presses,
trust fund that
and I
money goes
fucking
into it.
feel my
And so people,
fibers going
contribute
numb.
to it. So you
Like,
pay into
this
the
is my
trust
action
fund.
trying to
But then
find
people also go
on
through
those
that.
cable
Is
presses.
that they,
Obviously, good stretch of
the
time.
government can contribute.
I want to just.
And so with that then, is that then you go through that you
Can it
would do
be
it through an
described by
insurance
words?
company, or you
Just
just
fucking
directly, you sickness
I'm
fund,
gonna go do some side
basically
notes.
you get a sickness fund that pays for things.
I don't know what
Pays
movements,
directly to the
I'll figure it out as I
providers.
go.
So there's different
But
type
until
of
then, I gotta see
models.
if I can.
But the main thing is
hang
that
on
there's this
without
kind
ripping
of
it.
other fund out there, which
Like
is
the old faithful
that's
side
dedicated,
lateral raise machine.
it's actually to the provider. So the reason,
I mean, look,
the key
side
thing about
laterals
this
with dumbbells,
is that
side
in this
lateral
case,
machine,
the fund is
side
both a
laterals with
provider
fucking
and a
cable.
purchaser of healthcare.
At the end of the day,
And
all
this
you're doing
became
is
a
going
problem
from here
in
to
the,
here
as
with load.
healthcare costs started to rise around the world,
I feel like
is that
obviously
countries that
change it up.
have
Don't just do the
this
same
type of
workout every
arrangement,
week back to
where
back to
you
back.
have money coming
But
in
with such a simple
and
muscle like
that
side
they then
delts,
pay providers,
you
it started
I
to
don't
be
see
kind
why
of
you can't get solid
a
results
problem,
just spamming the same kind of
because
movement.
they wanted to make sure
There's
that
not-
they have to
There's
negotiate
not
with
many ways to hit your
providers.
side delts.
So what a
So
sickness
your
fund
routine
does
is
in this
just
case, then, the sickness fund is
2
actually
sets of side laterals at the end of
just
chest
like in
day
the
for side delts, and
US,
that's all you do.
Anthem Blue Cross are trying to
Just
negotiate
because, like, oh
with
well, I don't
healthcare
want to do
plans,
so many sets
healthcare,
on just one exercise.
hospitals and things
No,
like that.
just bust them
Well,
out.
that's what this
I've
group
had
does.
on
This is kind of a government
where
type group.
I
that
only did
negotiates with
alternating dumbbell
providers.
curls. You know, like the
In
standard
Germany, they
classic
also
dumbbell
have
curl.
a whole bunch of other,
I would do fucking
rather than
8 or
going
9
to
sets of
sickness
those
fund,
just in a
you can
row.
have private insurance,
I was
and private
stimulating
insurance
the
gets money,
targeted muscle,
and then does the same
and I was
thing.
getting
But
the
there's
badass
someone
pump
then
with fatigue.
who's negotiating
So as long as
with
you can get a
the
crazy burn
providers and
and
making
you
sure the
know
providers aren't
you're
just
exerting yourself,
sort of
I
adding
think
in
you're in the
other types
clear.
of costs.
You're in the green zone. But,
Okay,
one here, and
so that's the basic idea of
maybe I'll do
sickness
a couple
funds.
more, or maybe I'll just move straight to dumbbell lateral raises. I'll see.
The next one is a national health insurance. So this is now where you have this is Canada, where essentially people pay to the government, and then the government pays providers. So this is how Medicare works, right? And Medi-Cal works is that people pay their taxes, and that then that the government directly pays providers. So then if you think about how Medi-Cal works in Merced County, is that the state gets the money. The state actually then pays the Alliance for Health, and the Alliance is actually the one who does the Medi-Cal purchasing. So why does the state do that? Why does the state come through and say, well, we're going to fund this company, the Alliance, to basically do this, rather than just the Department of Healthcare Services do it. Department of Healthcare Services,
Let's do a couple sets of dumbbell
in
next.
Sacramento, they could pay
I'll change it up a
Medi-Cal
little bit. Instead of just doing my normal
They don't have to
standing dumbbell
go
lateral
through this other
raises.
company. So why
Set
do
a
they
bench
do
up
it?
on a
Well, the idea is
really
that
high angle. I don't know how many degrees this is. 70
they're trying to
something. Sit on it kind of
trying to get
sideways like
this other
so.
company to basically
do some
keep
singing
costs
on
down. And so what
Kind
they
of,
say is they say to
it's
this
the same
company,
shit,
okay,
but it's
through
a
the
little bit
Alliance, we're going to pay you a certain amount per
different.
person.
Just because on a
And
normal
that
dumbbell
you
lateral
then
raise,
have to
when you
pay
hit the
for
bottom,
everything out of
your hand
that,
is right
out of
below
that,
your shoulder. There's
those
no tension on
funds.
your side
So you
delts.
can't come through
But since you're at
and
this
come back and
angle,
ask for more money
even though I'm
later.
at the bottom of the
If
rep,
you,
my arm
if
is
you,
still
if your costs go up,
off
you
axis,
lose
off
money,
vertical.
and you
So
lose
there's
money.
just
On
constant
the other
tension.
hand,
So I
if your
think
costs go
40 would
down,
be
and you can
a
keep
solid
costs
weight.
low,
Let's
then you
see
make
how it
money.
feels.
And they can also, if this company, so that's the basic way it works. So you can see what the incentives are. The incentives here is that for this company is basically come back the next year and say, oh boy, things were really expensive last year. We just barely broke even. And so next year we negotiate our price per person. It's really going to have to go up. So what having a separate company does is allows the Department of Healthcare Services to basically say, well, fine, if you're not going to do it, we'll go to another medical purchaser and let them do it. So they're trying to create some type of competition between these medical purchasers. So, for example, the Alliance actually does Merced, the company
Covered
that does
California
Alliance
could
is
lower the
Merced,
cost of your health
Senator
insurance,
County,
and you might even
and
qualify
Monterey.
for $10 or less
So,
monthly
and the reason that they
premiums.
do all three of those is
To
because
save
Monterey,
money and
and
to
then
protect
they
your
do
health,
Merced,
visit
and
coveredca.com
they
today.
give the lowest price, and so the Department of Healthcare Services gave it to them. But at the same time, the Department of Healthcare Services next year turn around and say, forget it, we're going to pull our contract on that. So what they're trying to do is they're trying to separate out the funder, in this case, Department of Healthcare Services, from the purchaser. In this case, the purchaser is the Medi-Cal purchaser. So they're trying to create like a split. And that's what, the beverage model is what the UK model is. So the UK model is that people pay the government, and the government then, basically has the providers, like they pay for the hospitals, right? They run the hospitals, they pay for it. Well, I know that when I was first, when I first started working down in New Zealand, and Auckland Hospital, which is the big hospital, they came out in the first year and said,
one more little
there are
variation,
$350
and then we can check the pump.
in the hole.
I'm not really one to
That they
do
have a deficit.
anything super fancy with a big
And I
setup.
thought,
For the
oh,
most part,
man,
I think a lot of
a
movements like
deficit
that
of
are kind of
$50 million.
unnecessarily
That means you're gonna close
complex.
down. Because
But
Mercy Hospital came to
Same
us like, we have a deficit
angle on the
of $50 million
bench.
this year. Well,
Sit on it,
without
comes
the
around like
community
this.
hospital, done
then do some
there,
kind of chest supported side
they
laterals.
started running deficit.
That's always gonna
They
be a
couldn't
solid
get
burn.
loans, so
I haven't
they
done it
closed
for a
down.
long time though, so.
So
Start
hospitals
changing
in
things
the
up and
US,
throw a
they
set around.
close down.
And with this, I mean, I'm not
don't
going
make
heavy.
money.
Like I was just doing the 45s.
Well, so that's what I thought
And
was
you said
happening.
the single
So
on
I
ones.
was
But I'm dropping it down to 25s for
Boy,
these.
big news
Just to
on
really
that.
squeeze.
Auckland Hospital,
This is
maybe
the
close.
squeezing, burning
And
kind
he
of set.
said,
But after this,
man,
I'm gonna be fully
because
pumped.
this happens every year. He goes, because they know that Auckland Hospital is run by the government. So they know that the government's going to pay for it, right? What's the alternative? That they're going to close down the major hospital in the country? So they're not going to do that. And so there was like this, I don't want to say a game, but there's this back and forth that exists in countries like the UK between the government and the hospitals, where the government is trying to keep the hospitals from not spending too much. At the same time, they own them and they pay for it. So one thing that they do in these countries is that they create kind of other types of entities
So I guess I haven't said it for
that
a while.
actually do the purchasing.
Let's
So
not only should
they'll
we check
create
the
like
side
in
delt
the,
pump,
what
but
do they call it?
let's run over my current stats.
District
So
purchasers, but they're
40
like these
speed,
regional,
unknown,
they're government
probably
offices, but they're the regional
3.7
kind
seconds.
of purchasers.
Vertical
And what
unknown,
they do is that then they
height,
actually contract with the hospital.
5'11" and just
And
like a
the
little bit
hospital,
of
they
change.
contract with the
And then current
hospital
weight this
to
morning
basically
was
for certain
249.
type of things, like
So
they'll
I
say,
think
well, we're gonna
in the
contract
coming weeks,
for 50
I'm not going to be in the
hardware
240s anymore,
places
even on a light day.
for
And
this
I'll still
hospital.
be locked into 250s. And
So the hospital then has to figure out, well,
time is ticking.
who do they give a
Just
hardware?
wait for it. One morning I'm going to wake
Now,
up,
beginning here,
do
they
my
know
business
that
in
they
the
can only
bathroom,
do
step on the
50.
scale.
And
That
so
scale's going to
they
read
have to
260.
start figuring out, well,
That
how are we
would
gonna
be a fucking day.
prioritize this?
Not that
So what happens
numbers
if
fucking
November
matter. I just want to
comes
develop
and
muscle.
they've done their 50 hardware
260
places,
pounds of body
and
mass.
that they have more patients
Not
who
nothing.
need it?
Not.
They could go back to the government and say, well, we've got another 5 patients who need heart replacements, but the government can sort of say, well, managers
What do you
did
think,
a
dude?
poor
Jesus
job,
Christ.
and
Are
so
side
they get
delts
fired.
pumped or are they fucking
And
pumped?
so managers get fired a lot who can't kind of manage that type of flow. So it's that, so governments, what they often do is they'll come through and
But even the rear
they'll
delts
either
pumped,
give
man.
you a
All I've
budget
got
and
is
say,
side
you have
delts
to keep
pumped.
it in this type of budget. Or what they do is they actually get down the same. You can do this many of these type of
I
procedures,
gotta
this many
I
of
think
those
no
type
more
of
shoulders,
procedures.
dude.
And then you let the,
I mean, there are pumps that are artificially bigger, but that is,
the hospital.
I don't wanna say it's too much, but I think that's too
How
much
they're
shoulder.
prioritizing,
I want
how they're
to
gonna choose who to do.
delegate the amount of nutrients and
Do
growth
we have
that
to
are
do
going
that?
into
Does
these
Mercy have to do that?
and kind of spread that out and focus
Does
more on
Mercy have
chest,
to, have to
arms.
sort of, what happens if a whole bunch of people
Fuck, man.
come in
I
and
can't
then
even
they
reach
need
behind my fucking back
these
to
surgeries
do a
into
really good
Mercy
side
Hospital?
tricep. But I
What will
mean,
Mercy Hospital do?
that's a fucking shoulder pad if I've ever seen one.
Would they say, sorry, we're gonna
Let's get a
prioritize
couple
on
more
these
and then
surgeries?
roll.
No, they would go, good news, we're gonna go hire a new knee surgeon to
So that's
come
it.
in. So,
Did calves yesterday. I
if
can
all
still
these
feel them
people
a
can
little
pay
bit
for
today.
it, then
So
they'll
we'll save
go
them
ahead
for
and
tomorrow
try
with
and hire someone
back
in,
to
or
rear
what
delts.
they'll do is they'll contract with,
Let's just
you
get
know,
in the car and eat.
they'll go to,
Well,
down
get
to
the car,
Fresno, the community
go
hospital,
home,
and say, hey,
and then eat.
why don't you send your doctor up here twice a week for the next 3 months, so we can do all these things and we'll split
You
the
might
money.
not feel it, but it's
So,
there. Staring
in
back
this
at
type
you.
of system.
It's time to change your outlook and
Is that
see
you don't
yourself
have
cured of Hep C.
priorities.
Today's treatments have
But down
poor
there,
cure rates of 75% or
people don't
higher,
have to
are
pay for
pills, not injections, and can be taken
replacements
wherever
is
you
that the
are on your
government has to
recovery
have some
journey.
type of
So
way
start your next
of
chapter and
controlling
put Hep C in the
what,
rear view.
how many
Now's the
researchers
time to
do
see
they do.
yourself cured. Talk to a healthcare professional and visit HepCure.
So that's
for more
the
information.
type of UK, that's the system
I
that
want it to be
exists
the
in most
best
places.
Christmas of
That,
all
so
the
even though
Christmases
that
ever.
the providers
I'm here to put a
are
little
oftentimes
hole in
paid
your
by the government,
stocking.
they're still seen as
Let's do this.
they try to
We're
set
not
up
gonna let an elf turn
these
your
kind
dad
of
into one of
false,
those weird
these
happy
types of
meal
ways
toys.
of
No
trying
offense,
to
I'm sorry.
treat them as if
A
they're
little
still
trigger.
purchasing money as a way of keeping down costs.
All right, so
Okay,
I think this is worth mentioning.
so
Am
in
I
these type of
concerned
systems, if you turn around and say, well,
with
who
putting
is
on
it
some
that's
body fat?
that's
Am I
negatively affected?
concerned with
Right?
a body fat
Well, in an
increase
out-of-pocket
bulk?
system, it's basically people who can't
Answer
pay.
that question
Right?
is
People who have no
absolutely
health insurance or just people who can't pay.
not.
In a private
End
insurance
of the
system,
last bulk,
right,
I was a little bit
is that
upset with
people with
myself that I wasn't a little
employer-based
bit fucking
insurance are the ones who have
Because all
to,
that meant was
are the
I
ones
wasn't eating enough food.
who
I am very
that's where
comfortable with
if you want
losing abs,
if you want to get
losing
insurance
weight,
in a private-based system
in
like
exchange
ours,
for
that you
the
basically
gains
have to
that I
have
will
it
make
through an employer-based system.
on the bulk. So I
In a social insurance market,
I think in that sense I
right,
got my
then
head
you're
screwed
going to
on
have people
pretty
paying
solid
into
way.
the fund. So it's the fund that
This is,
the sickness fund is
When
actually
it
the one
comes to
who is
bodybuilding progress,
doing all the
or just, well,
negotiations.
even if you're not an
In the
actual
national health
physio
model,
bodybuilder,
where
if you're a lifter,
like Canada, is
unless
that
you're
then
powerlifting,
again the government is responsible for it.
basically, you're trying to grow muscle.
And then
That's the name
in
of
the
the game.
UK model, it's the same thing.
So it can be pretty freaking easy to
So
get
point
upset
being, we have all
if
these nerve systems.
some surface level stuff like your leanness begins to kind of fade if you try to
But
start
other type of even
fear of
even in these other type of
getting just a little bit
healthcare
tubbier.
systems,
Now,
is that
obviously,
oftentimes they have
like
they
I
don't
was
just
gonna say
only
relatively
have like the
lean
UK
bulk,
doesn't only
and
have
the cardio's gonna
this
help
type
with
of
that as
model.
well.
The
But
UK
fear
also
of
has
kind of
private
losing your abs or
insurance,
losing some veins,
so you can get
I
private
think that
insurance if
stops
you
a lot
want
of lifters from
in these
trying
types
to
of
actually
countries.
bulk up.
But typically, what it is,
And
it's
I don't
called
even need
gap
like a freaky ass
insurance.
crazy
That is
bulk,
that
I'll tell you
it does
even
things
just
that
a mild
that,
surplus.
the National Health
I
Service
feel like a lot
won't
of you
do.
guys get caught in a state
So, for
of-
example, gap insurance could be
I almost want to say failure to launch because you've been
if,
lifting for a
well,
while,
like,
you've made some gains.
if you
but
are
it's
sick,
starting to slow down,
if you
and then
get cancer
you're at a
in the
crossroads.
UK, right,
I always hear
and
news
you go
stories
down to the
where they
hospital,
go, well, I think
then you're
I'll
gonna
start
get
cutting
your
a little bit, or
by
I'll
if
start
they can
bulking.
do it, they have the capacity.
I'll start that.
Then they'll treat you in the national health system.
Kind of fades out.
So if you have something really serious in these types of
What they've always
systems,
done,
they tend to
which
you get moved to the front of the
that
queue and they treat
nature
you.
of training going
On the other
into
hand,
pretty much
if
the
you
same
come
shit
in
every
and let's
day,
say you have a
there's nothing wrong with that.
a
But
knee that's
kind of
been bought
wanna
that's 18
make
million
some
off,
kind of progress, right?
but it's not
Unless
an
you're at a point
emergency.
where you're just trying to
It's
maintain
elective
your
surgery.
health,
You know, if you were in our
everybody
system
should get there at some point.
and you went down to Mercy and you said, I got a
Unless you're
knee,"
there,
and they would say, well, let's see if your insurance pays for it. If so, then they schedule you for a knee replacement.
if you can tell you haven't
Well, in
really
countries,
pushed
most
it,
countries,
and I'm talking about like your
particularly
training
like the
intensity,
UK, what happens is that if you have an aching
too
knee,
many off
is
days
that then they may
unnecessarily.
not,
You haven't been
they
hitting
only
your
give you a certain
protein, you
number
haven't
of
been taking
knees
your
a year.
creatine.
So they're not going to
You definitely
necessarily
haven't
go
been
through
fucking
and
taking
put
your
you
fish
to the
oil
top
like
of
you
the
should, your
queue.
multivitamins,
They may have a wait.
or doing your daily cardio. That's
So
probably
what you can do if
one
you want
thing
is
that
that
you
you
could be doing.
you can go pay for a
You
private,
can tell that
as
you're
if
just
you
kind of
could go
going
down
to the gym a
there
little
are
bit.
private clinics. So you just go down to a private clinic and say, well, I'm willing to pay the
Yeah, I kind of
10,000
want to say
pounds
half-assed
whatever it's
it.
going to take
Then
to get
all
my
that
knee
effort,
replaced,
I
and
feel
they'll
like
do
to
it
an
for you.
extent it's getting wasted.
So, or you can buy insurance, and the insurance then would say,
There's
if you
not
need a
a
knee
massive
replacement,
difference.
that, and if the
There's not
public
a
health system
massive
won't do it,
difference in
then we'll go
effort
ahead
level
and do it.
of
So it's not insurance that
maintaining your
covers
build
everything.
and
It's not like insurance
progressing.
here that covers all your.
Honestly, they're
Instead,
relatively
it's
similar.
gap
Now,
insurance
obviously,
because
if you
it's
want to
basically
progress, you're gonna have
covering
to put a
things
little bit
that
more effort
the
in.
National Health
Make sure
Service is
you're
not.
really training hard. Make sure you're hitting your macros.
Another thing that like,
It's
for
not
example,
effortless, but it's not
secondary
that
surgery,
much
seeing
more effort
specialists.
than a
Oftentimes
lot of
in
you
public
guys may be
systems,
stuck at.
the wait to
just
see a specialist
maintaining
in the
your
public
build,
system
you
is really long.
I always
Like
kind of
if
think
it's
of
not
this analogy.
cancer or something like that, the wait can be really long. So,
You can look at two dudes.
if you've got,
They both go to the gym
if
every
you've got
fucking
something
day.
where it's not
And let's say they do
it's
their
not
cardio
an emergency,
And one guy
that then you might have to wait a
hasn't
couple
been
months to see a
eating
specialist.
his meals.
But in a lot of these
Honestly, that's the
systems,
number one factor
you can also
to
go
decide
and
whether
just
you're
see
pro or
the
not is how how many
You can
calories
just
you
go
can
and
get down
pay
your
to see a
gullet.
specialist out of pocket.
Yeah, They
So
both
you
go to the
pay
gym every day,
$250 or whatever
and
it's
they
going
both
to
want to
be, have
bulk
a
up.
specialist appointment,
And one
and you'll
guy,
see you the next day.
he's just not eating.
So what it does is
not
that
eating enough
the,
meals.
they
He's
have
not
these
getting protein. He's not eating enough fucking
kind of
frozen
ways
mac and
around the
cheese or
system
ramen or
most of the time.
instant rice.
Now, that's not true in Canada.
PB&J,
Canada,
whatever.
they've
He's
set
not
up
eating
their
enough
system
calories.
so
That's
that
this guy.
they say to
This guy
providers
over
like
here is
doctors,
fucking slamming calories. He's hitting the surplus.
if you're going to take money, if you're going to see the patients that you pay for
Steaks,
by
ground
the
beef,
Canadian government,
chicken, and
that
turkey
you
and everything
can't
else.
just sort of take money from the private
He's
insurance
really hitting the
companies.
surplus.
Does it, if
Every day
our
they go and
money,
do their workout.
if you want to be a private
Like the guy
doctor
isn't
and
eating
just
enough
work
food,
privately,
and maybe
you
he's
can do
not
that.
optimizing
But
everything else about
then
his
you're not going to see our
recovery,
patients. You're not going to see the
like
majority of
sleep
Canadian
and
patients. If you see our patients,
that's all.
then you can't
That's the only other
take
thing.
private
Just
money.
put sleep.
That's why when you hear about, like in Canada,
Maybe not
you hear
sleeping,
about this on
sleeping enough.
Tuesday, the movie,
And this guy's on
people
track.
from Canada coming down
One
and getting
dude,
care
he digs a hole,
in the US,
and the
driving
next day,
across the border.
he just fills the hole back up.
The
He just constantly
doctors
goes
on this
in and
side,
out, in and out,
they
in and out,
can,
in and out.
they
But the
can
other guy
provide
digs a hole.
services for people
And
who
the next
come
day he
home
digs the
and
same
afford to
hole.
pay for it.
If you can
But
feel
people,
it,
but doctors on the other side,
so
they
basically, one
can't.
dude,
So even if you
doing
come
the
in there
same
and
shit
say,
in the
here's my
gym.
$10,000 I
like
want
he's
knee
still
surgery,
digging and moving
they
dirt
won't,
around.
they can't
But
do
at the
it.
end of like 6 months,
So
he's got no hole.
Canada's
He's
an
made no
exception.
progress.
Most countries
But
have
the other
some
guy
way
has
out
made a big fucking
out
hole.
of this, where you have
And
some
every day
type
he's
of
actually
private,
taking steps to make
private
changes
pay-as-you-go type
rather
thing.
than steps to just
But it's not for
maintain.
the really,
If
really
you
big
kind
things like
of
cancer,
follow my
heart,
analogy,
heart
it
transplants,
makes
and
sense
things
in
like
my
that.
head, but
That's
I
not
don't
what
really
it's
totally
for.
explain it.
It's just for things like
But basic
knee
gist, if he can tell you
replacements and
haven't
other
been
type
making
of elective
progress,
things. Or it's for things like getting nicer rooms. So, in these countries, they typically have private
go up to the
hospitals.
biggest dog
And
in
private
the gym,
hospitals only then cover sort of certain type of
fucking
basic type
ankle biter,
conditions.
try
So
to
they don't
extract
cover,
some knowledge
they're
from.
not going to do everything.
More often than not, I mean, I feel
And
like
but they give you like your own room,
Well,
they give you better food and things like that. So if
mid-workout,
you
of
want
course,
it, that's important to
I don't
you,
want to
then
start
you
like
can
a
buy
20-minute
private insurance and
conversation.
it
But
will
when I'm
cover
done
your
with my
stay
lifts,
there.
I'll sit
Or
there
you
for
could
fucking
just pay
hours
for it out
talking
of
about
pocket. But
whatever.
if you're in a private hospital,
Oh, what have you been doing for
in
chest?
these
Yeah,
countries,
I've been trying.
and
Well,
let's
you've
say
been
you go
trying
there
to
for your knee
That sounds great.
surgery,
Well, what have you been eating?
and that something happens, and
That's
that
kind of
you said
weird.
you have a
Why'd you do that?
complication, what they'll do is they'll put you on an ambulance and send you up to the
You can
public
get a lot of
hospital.
fucking information
Because the
online.
public hospital is the one that
Actually, I
has
guess
all
you
that,
can probably get as much as
has
you
all
need.
the
But
best
in
equipment.
person, talking
It's
to
got
somebody who's
the
actually got some
most
results,
staff, the most specialists that are in the public
understanding
hospital,
their logic
so that
behind
they
some stuff,
don't.
that's
They
pretty fucking beneficial.
they're really just the private hospital, the private sector in these countries is really
I
just
almost feel
something
like if you're a
to
beginner
do
in the
the
gym and you
amenities,
talk
do
to
the
some
gas. But
more
anything that's
experienced
essential
people,
to
it's like a
do
fucking
is done in the
apprentice.
public hospital.
like a lift or
Um,
something. You're just getting in there, getting
If you
maybe shadow the masters.
if you go to other countries that
Maybe
that
not
have
masters,
more
but
like
they have dudes
like
more experienced than you.
Colombia.
Just by kind of
Colombia has a
monkey
system
see,
whereby
monkey
they have
do,
private
copying
insurance and they have private
aspects of their
hospitals.
trainings
And they
into
also have a
information
lot of
as to
people
why they do certain
who are
things,
on a sort of
what
a
kind of
government
benefits
type
they
of
think they get from those
of
certain
healthcare
things,
plan
and then
that basically just
relating
pays
that
for
back to your own training, your own
just
build.
some essential things is about
That's
it.
the way to fucking do it.
Well, in those places is that there are
I guess really what I'm trying to say is
private
the more
hospitals, but those private hospitals are not going to see
information you can
the kind of the low income patients
digest in
who
your
are
brain about
who would
lifting.
come in. Instead, there are other
I
hospitals
guess
that
that could
those
go for
patients
fucking
would go to.
anything, you know? I mean,
So in
Makes
other
sense.
countries,
You
you
study
do
more,
have
you
that
get better
separation
grades.
whereby the public hospitals become the
learn
primary
more shit
hospitals.
about
And
lifting and how to lift and what works
the
and
private
what
hospitals
doesn't
become the primary
blah,
hospitals.
blah, blah.
And the
And
public ones
you
are then just for,
try some shit out
for
for yourself
everyone
and see
else.
what
That's kind of like
really works for you.
what's like in
And
Los
get better
Angeles. So Los Angeles,
Looping back
if
to
you
the
have
initial part of this little talk,
if you
I
have
kind of gone on a whole rabbit
disability
fucking
insurance,
tangent about
which through
motivation,
through
troubles,
Medicare,
whatever.
Cal, which doesn't pay
Don't be afraid
very
to
much
lose
at all
your
for
abs. If
reimbursements,
you're just
is
a
that
gain
private hospitals
180
aren't.
pounder
They'll
and
stabilize if you
bench
come in
plateaued, you're not
and you're
really
bleeding.
making big
They'll
jumps.
stabilize you, but then they'll get you out of there
Clearly
as
you gotta
fast as
change
possible.
something up.
Because what they'll say is well, where do you live?
More fucking food.
And if you say,
Calories
well, I
in,
live
calories out.
by USC, and they'll say, oh, you go to the Martin Luther Hospital, Martin Luther King
More
Hospital.
calories.
Or if you live in Long Beach, they'll say, go to Memorial Hospital. Or depending upon where you live, they'll send you to the kind of the
Can't
the
say
more
that enough,
public
but
hospital in that
that's all I
region
gotta say.
to treat you because they
Some cardio in the morning.
they don't want
30
to
minutes. That's
In fact, they'll tell you, they'll say, oh,
that's not
sorry,
even
we
30
don't have
minutes of
any beds
cardio.
available.
That's just
And it's not that they don't have any beds
30
available.
minutes.
It's
pretty
they
much
don't
half an
have
episode
any
of The
beds available
Sopranos.
for
And that'll fly by like
patients who are only
nothing.
to pay 30% of what private patients, private insurers
Take a
pay.
ribeye,
So that type of thing
pounds
does
of
happen
ramen,
all the
so that's
time.
going to be about
That's a common thing
100
that
grams
happens
of
in
carbs.
the US as well.
honestly, with the ribeye plus.
But but that's because our public hospitals are not kind of the best hospitals, right? The best hospitals are
solid meal if I've ever
Stanford
had.
Hospital, these other ones that maybe they do a lot of care
I
for
have been irresponsible.
low
and
income,
fucking
but they're primarily
laundry
kind of
pile.
high tech hospitals.
I'm not so crazy that I like.
Okay, so the point to note about these things is that in these countries then that have
I'm
these
sure
kind
you
of
know
universal
somebody like that.
systems, is that waiting
Their
times
whole
are the
mess
primary
is a
problem.
fucking.
And see, that's the
I'm
reason
not
is
that crazy
because
though, but I'm in a
because
fucking pile.
if you think about, well, what is
But
it
I'm
that
not fucking
in
excited
those
to do it
systems,
because
what is it that's
laundry
going to
machine,
cause someone to,
washer and dryer,
what's going to keep
they're like
the
half
number
the
of
size
people who
of
want
normal.
knee replacements
So I'm gonna be doing
low.
like 5 loads.
So
But I'm
this
running
gets
out of
into the
fucking pump
needs
covers.
versus wants discussion
So maybe that's my cue that I
because,
should
like, for example, if I had an
get my
aching
fucking
knee,
house in order.
do I need to have a knee replacement? Or let me ask it this way. What's the criteria that I would use to figure out whether I needed a knee
Still kind of
replacement
lazy.
or whether I could get by with just,
Just
putting
get
a
back
brace
in
on
the
it
crib,
and taking some painkillers?
get ready for bed. So
Yeah.
I don't fucking. See you next time, man.
Well,
Get Google Pixel 8 Pro
I
free
mean,
with eligible trade-in and
and these type of
8
systems where it's paid for when people aren't paying for it. And so someone else has to, and basically the government has to decide who's going to get knee replacements, right? What's the criteria that you're going to use to get a knee replacement? Yeah. Maybe. Yeah. I mean, you're coming up with a reasonable type of criteria to use, but when it comes down to who actually is going to, who's going to make up those criteria? Yeah. So you're thinking about coming up within the system for basically making this decision? Is that what you're thinking? I mean, it's like if I'm a doctor and I've got 5 patients, how do I decide? And I'm told I can't give them all the knee surgery. How do I decide which of the 5 I'm going to give knee surgery to? I mean, you want to use criteria like age and things like that, right? Do you have a? Yeah, and so what you're coming up with is basically this prioritization criteria. And so that's what countries do, is that they come up with their criteria that they're going to use to prioritize. But if, and why do they have to do that?
A lot of people have said Omni-Man doesn't do a lot of damage, but
all
now
5 people may
new
benefit
combo routes
from
have
having
been
knee
found.
surgery. But if they're only going to offer to 4, then they've got to figure out what the criteria is, or 3. And so, what the reason that waiting times are a big issue in these countries is because that criteria is not really firm. It's hard to get a firm criteria to separate out people
So
who
as you can
just
see,
need
by himself, Omni-Man can now
just medication
consistently
and
get over 400
pain medication,
damage
which
with
is
one
not
bar.
bad.
However, what
Versus
is
those who
even
actually-
more crazy is you can
Where
actually
in this
do
country,
all these combos
because
meterless.
get the money,
It's a lot
you can,
harder to do.
you can
For
get it
example,
done,
this
you
is
don't
the
have
back
to
1-1
you
combo.
don't get
Before
it
we
done.
were getting like
But other countries
30,
have
now
to.
well
So
over
that's why I said
400.
the waiting
And you
times
can't really do it
is
from his
a-
1-2
is the kind of
starter
issue in
unless
these
you use a
countries.
cameo like
Because
this. And
they-
once again,
yeah,
from
once
his
you
jab,
remove
you
costs,
can now get
once you
well
remove
over
the-
400.
how much
Now
is
this
it?
is meterless,
But
but
then
I
you
do
pay-
recommend
and
using
then you
the
can say-
version to
figure
make
out how
it
much
more
you can
consistent.
and
I'm
devise it.
definitely gonna drop a lot of combos,
All right,
but
well, we're
let's
almost
try
out of
and
time.
get these online.
So,
Okay, let's see if I can
Tuesday,
get these
movie
combos
day.
online. My
I'll
muscle
send
memory
out
is
the
gonna be
link.
completely wrong at this
The
point.
information
Basically,
about
if I can get any
And then the
hint, I
following
should
week,
be able to. Oh, okay, he's gonna finish that.
guest speakers.
Should be
and
able.
Zoom
Oh, look at
meetings.
that conversion though.
Good.
Walking high because I don't want. There's the overhead, and I didn't go into Kung Lao. Okay, my muscle memory's already doomed. You're not that guy. Nice.